acute coronary syndrome. My name is Margaret Arstall. I'm a cardiologist at Laila McEwen Hospital, and I'm your chair for this evening. Just as a little Zoom etiquette, if you could please put your video and your audio on mute. And when it comes time for questions, if you go down to participants, there is an area where you can raise your hand and we'll be able to see that you'd like to speak and ask questions when it comes to the panel discussion at the end of the seminar. Also, there's a request that if you haven't already done so, could you complete the 5-minute online ReCare survey, measuring clinician attitudes, values and beliefs toward cardiac rehab. This is part of the CHAP project to find out where we stand and see how the attitude towards cardiac rehab can be improved. You'll be able to find the link to that. It's on the request email that you received. So after all of those little bit of housekeeping, I'd like to introduce Matt Worthley, who's our first speaker, and he's going to give us a brief overview of the CHAPS study, or the Country Heart Attack Prevention Study. Matt, many of you may know, is head of unit at Royal Adelaide Hospital, cardiology unit, and is an interventional cardiologist. He is passionate about all of his clinical work, and I've worked with him for many years. He's published, he's certainly a clinician scientist, and has published over 100 manuscripts in the area of cardiology, vascular dynamics, and especially intervention. And he's been on the board of the Cardiac Society of Australia and New Zealand for quite a few years, and the advisory local board for the Heart Foundation. So I'll hand over to Matt.
Thanks, Margaret. I'll just make sure, I think I've got that up. Can everybody see that? Margaret, can you see that?
Certainly can.
Oh, very good. Okay. So I was really delighted to be able to have the opportunity to speak briefly about the CHAP project. This is, should be absolutely passionate for cardiologists that believe in best outcomes for their patients, and particularly would be acknowledged to be a small hole in the system, particularly in regards to our cardiac patients, to ensure that they get the same level of, country patients, sorry, to ensure they get the same level of care as our patients do from the city. So as a brief acknowledgement of country, we acknowledge that the CHAP team is spread across many of the traditional lands. We pay respect to all traditional owners of the lands and those who under custodial law are charged with nurturing and protecting country. We pay respects to elders, past, present and future. So the CHAP program has a passionate team that initiated the thought process back in 2018. And so Robin and a band of passionate people submitted this grant. A number of cardiologists also initially engaged in this program. To name a few is John Beltrami and Derek Chu and Steve Nicholls, and submitted and were reflective of the important aspects of this program, received a large partnership project grant from the NHMRC, and as such further funding from other sources to enable this, importantly, to be supported fiscally to ensure that it produces its outcome. So the Country Heart Attack Prevention Project, the aim, and this is quite a mouthful, it's a use of a translational methodology combining a prospective case control design with a model for large-scale knowledge translation and comprehensive economic evaluation to implement evidence-based cardiac rehab into rural and remote practice. I sort of tried to break that down into language that I can better understand, which is basically they're going to establish a methodology and then prove its effectiveness and be able to roll it out to ensure that it actually does provide good clinical outcomes and they're going to do so acknowledging that everything in our society at the moment needs to be able to be fiscally aware, and they're going to ensure that that is economically viable. You can see on the right-hand side of the screen there that the CHAP model includes a number of different processes, and I suppose as a cardiologist, I might in this initial phase just emphasise the utmost importance of the endorsement and rehab by referring clinicians, not always, but often cardiologists. The model then involves an auto-referral system, a choice of model and delivery, and long-term support for heart health from primary carers. And this is an important aspect of the program. It's enabling, it's providing resources and education resources, largely in an electronic format, but it's also empowering and enabling the resource at the location, which I believe is a key and critical part of this model and program. And then finally, the evaluation of the clinical and cost effectiveness. To dive a little further, the design, the project, as mentioned, will use translational methodology, prospectively study, and then provide economic analysis. The setting is the rural and remote South Australia, and it's via the established iCarNet program with which Rosie and Phil have been running for a number of years now. The current guidelines state that cardiac rehab programs should be offered to acute coronary syndromes, and that includes not just myocardial infarction, but also unstable angina, chronic ischemic heart disease, heart failure, and arrhythmias. This includes often patients that undergo angioplasty, stenting, and bypass surgery, along with device insertion of pacemakers and defibrillators. The recruitment, consent, and ethical considerations must be abided by in regards to this program, and patients will always have the option to opt out. Consent will include a data sharing permission statement and future long-term follow-up. So the key process and the key initiation, and I suppose it's, as I mentioned before, is what I will emphasise, is the important and initial leading step of getting the doctor or caring physician to recommend this process and program. The audit of professional behaviour within feedback of results is associated with increased compliance. So anyway, this is the important issue to be able to recommend for our colleagues, this program. Why is it important? Using 21st century methods of influencing, and we need our clinicians to engage, and what the CHAP team is encouraging us to do here as cardiologists, to engage and to come up with, I think it's called a video wall or something. Yes, there it is, a video wall. And to ensure that we have key opinion leaders to recommend not only cardiac rehab, but this program. And so the CHAP team will show a brief video here. They've opted to choose an old cardiologist and a young cardiologist to be able to articulate this, and we're hoping to add further. I'll let you guess which one's the old one and which one's the young one. So if we can move forward to that.
My name's Professor John Beltrami, and I'm a cardiologist, and I recommend cardiac rehabilitation for all my eligible patients.
My name is Matthew Worthley, and I'm a cardiologist, and I recommend cardiac rehabilitation for all my eligible patients. So I'll leave it there, Margaret, and hand back to you.
Well, thank you, Matt. Moving on, we're very appreciative that Novartis Pharmaceuticals have sponsored this evening's webinar. And I'd like to now introduce Laila Chamma to say a few words about Novartis working in this area. Laila is a Director of Business Transformation Unit at Novartis Australia and New Zealand, and she's an accomplished leader with a career spanning over 2 decades in the pharma industry, and her role is to explore new boundaries of applying healthcare technologies, innovative partnerships and new models of care to transform the patient's journey of care and to improve health outcomes beyond the pill. Thank you, Laila.
Thanks for the introduction, Margaret. And like those before me, I'd like to start by sort of acknowledging the traditional owners of the different locations that the audience is at today, and pay my respects to the elders past, present, and future also. So I'm honoured, I guess, to be representing Novartis Australia and New Zealand. I think some of you may know that we're the largest medicines company in Australia today, and we have a very big focus on cardiovascular disease and the various elements of cardiovascular disease in both our current and our future pipeline, because it remains to be one of the sort of areas, it's an area of high unmet need, and as it represents a significant burden for our population and our healthcare systems. In Australia today, currently we invest about just over $12 million in R&D, not just in cardiovascular disease, but cardiovascular disease is one of the strongest portfolios that we have, both internally and within the industry. But on top of that, roles like mine and departments like mine exist today, and they're relatively new in Novartis. Like, I've only been with the company about 14 months now, and it's a representation of the investment that we're putting in, as Margaret sort of alluded to, kind of beyond the medicines, because we acknowledge and we realize that there's a lot more going on in a patient's life, in their journey within the healthcare system, with their disease, with their family, that goes well beyond the medicines that they're taking. And we're investing in smart people, we're investing in technologies and in partnerships to really help us understand what we need to do to support the transition of care of patients and their families across our 6 therapeutic areas, as I said, of which cardiovascular disease is a massive area. One of the reasons we're doing this, I mean, the proliferation of kind of data and digital technologies in our in healthcare is seismic in terms of the shifts that it's causing, and every day we are able to get new insights into personalized care or new targets, and we're really trying to work locally with systems of care or the corporates out there to really try and use some of the latest and greatest in AI and to understand, to connect data sets to help mine for deeper insights that not just give us the data that we can have share publications on, but to help us really understand what the biggest pain points for patients and their families are, or for the system of care. And then help us to, create consortiums like you guys have created with the CHAP study here, to try to solve for some of those big pain points. And we understand and acknowledge that we can't do this alone. This needs to be done in partnership, and in collaboration with groups like yourselves, which is why we're sort of committed to working together with groups like the consortium here, on hugely important programs like the post-MI sort of prevention and study that you guys are, or that we're sort of proud to be part of, to really sort of help alleviate these burdens and do what we can to raise the standard of care for patients. So this is why we're hugely privileged to be part of this consortium, and committed to doing what we're needed to do to support you guys on this journey, to share our knowledge from either what we're doing in other therapeutic areas locally, or what we're doing globally as well, that we can sort of draw on from a skill set. So with that, again, very proud to be part of this consortium and wish you guys every success at every point of the journey that you are on today and for the future. So thank you again for allowing us to have this word. Back to you, Margaret.
Thank you, Laila. That's wonderful. I'd like now also then to introduce our next speaker, which is Krolig, who will talk to us about her own cardiac journey. But Laila is a health policy manager with Country Primary Health Network South Australia. In 2013, she had the unfortunate health issue of a heart attack and began the journey to recovery by attending a cardiac rehab program. Ali will share her insights on her recovery from a consumer perspective. Thank you, Ali.
Thank you. I'm just going to get this started. Hi. Thank you very much for having me and listening to my story. I too would like to acknowledge the Aboriginal and Torres Strait Islander people's land on whom we meet and pay my respects to elders past, present and emerging. I've had an interesting journey. I'm now 53 years, and I'm not 53, I'm now 58 years old. There's been some things happen in my life that kind of led towards this event happening. What I've done with my slides today was to endeavour to give you a story, but also to provide a bit of the clinical background on my journey of my heart disease as we go. So at the time of my heart event, I was living in Kapunda, in Tanunda. I had psoriatic arthritis and hypertension and depression, and I think I've actually just jumped a slide because this is where I was. Okay, so as you can see from my slide, I was really severely overweight, high BMI. I was brought up in rural South Australia, second to last of 7 daughters. The family history is actually quite troubled with lots of different things. And really, as far as that goes, you could say it's a bit of a comedy of errors, starting with my parents having children. Our family has DNA littered with rheumatoid arthritis, osteoporosis, the psoriatic gene, which includes arthritis. And then there's generations of family that have had hypertension and a variety of cardiac conditions, including my mother, who had a cardiac event at 55 years of age, and my father, who had triple bypass surgery at 65, along with numerous family members, including my mother, grandmother, and uncle who had strokes, we also had the risk factors of, good German food, and my father smoked a lot, and that ended up with my sisters, mostly, who smoked. I think only one didn't. So there were some precursors to my event. I didn't know that at the time. And really it was when I started thinking about it a bit later, following the event, and in actual fact over a couple of years of thinking about it, I actually may have had the first part of my event on the 15th of March when I was walking uphill in Sydney and had shortness of breath. Sorry, just go back there. I had shortness of breath and pain and tightness across the shoulders and shoulder blades. But
Krolig, you might want to try and share your slides. They're not showing.
oh, aren't they?
Yeah. See how you go.
Mm. I'm not quite, I don't know why. I'm just going to go like that.
Your story is still telling it. You're still telling a good story even without the slides.
Share screen. Sorry, I thought I'd shared the screen. Sorry, is my screen shared?
Not yet.
It's telling me it's shared. Okay. I'm so sorry.
Now, if you go to PowerPoint presentation, that would be good. Just, perfect.
My apologies. So I'm just going to go back here. Precursors to my event. As I was saying, event in Sydney. Just assumed that it was soreness from kayaking. Then had some pain on Friday, and then following that, it was just kind of like a feeling of tiredness. I did have a PT session, but I moved that to the Wednesday because I was still feeling fairly run down. So, for some of you, you might go, oh my God, she should have been at the hospital on that 15th and not left it. So, it's until you actually experience the event, it's really difficult to understand what it is. So I was admitted to the Laila McEwen, but first to the Angaston Hospital when I had pain and an absolute feeling of heaviness and tiredness whilst in the pool doing a PT session. And it was that heaviness that really got to me. I just couldn't move. Really, really quite difficult. So ambulance came along, picked me up. They gave me a spray under the tongue. I felt better. Sitting in the Angaston Hospital having a bit of a joke with my personal trainer. She'd come with me to the hospital. But no, that's actually wasn't it. I'd actually had a heart attack. And so here are the stats of what that was. So even having had a heart attack, I felt okay. I wasn't quite sure, what all the fuss was about at that stage. But as soon as the troponin results came back, they whipped me off to the Laila McEwen. And we went through get me into have a angioplasty. Sorry, it was an angiogram to start off with, and then, of course, an angioplasty straight from that. As a patient, but also a person who works in health administration, I'm part of the Country SA Primary Health Network, so we're a commissioning body. I actually was really interested from a academic point of view, what happens to people in when they go in for this angioplasty. And so being able to see what's happening on the screens and talk to the cardiologists while they're doing their thing and just hearing the whole message was actually a bit of a buzz. So did I actually remove myself from the actual thing? Was it me who was there on the table? Maybe that's my way of coping with it. So I did go through and get through the next day and was discharged and had the normal information along with My Heart, My Life book from the Heart Foundation. But I've got to say that, you know, when the minute you step out of that hospital, everything kind of falls away. It's like being in a state of shock. Did I understand or remember anything that the cardiologist who was doing my discharge had said? Do I remember anything that the pharmacist had said when she'd taken me through what drugs I was going to need to be taking? And that was quite extensive, as you can see. So along with, you know, my normal drugs, which, you know, is about depression and managing my arthritis and high blood pressure and I was going to say, and high cholesterol. I'll go with that one. There was the added cardiac drugs that I would need to take, and understanding when I would need to take them and how I needed to take them. So there was a lot of things that kind of had gone straight out the window the minute I was in that car back to my sister's place. And I think that this is probably one of the really important things to take on board about cardiac rehabilitation, or in actual fact, discharge of any sort, but in particular anything where you've had a major life instance that means that you need to change what you're doing. You need to understand what it is that's happened to you, and then if you don't do something about it, what will happen next. But just getting through the first week of discharge, following discharge, is actually a really major challenge. On two sides, there is, what do I do now? And who's going to help me? So, you know, the first thing is, okay, you need to make an appointment within 7 days to see your GP. That's fine. Okay, I can do that. The first, you know, couple of days need to kind of relax and chill, make sure that you've got somebody looking after you. For me, I was actually reasonably lucky. I had a sister that I could go to, as I do live alone, and have done for many years. So actually being contacted, I think it was within 48 hours, by somebody from health to find out what kind of rehabilitation I would like to engage in, was actually a real, made me feel much better about where I was going to. And I'd say happy, because you know, that not feeling confident about what I was actually going to be doing and what I could expect over the coming weeks, months and years, was actually kind of a bit daunting. You'll see some information here as we go through. I did actually go through a readmission and a planned readmission, which was fantastic, because as you'll see in a moment, I did have fairly extensive ischemia and lots of blockage. I think it was 98% on one side and something in the 80s on the other side. So, you know, I was a walking death trap. So following all of this, I did choose to take up the catch program rehabilitation. I did that for a couple of reasons. One was that I actually work. I work full time. I have a very busy work life and did at that stage. And so actually doing a face-to-face program It was just not within my ability to do that. And nor were I really particularly interested in doing that. So the other reason was that actually our organisation funds the Catch program, and I wanted to check it out from the inside. So taking the journey, being able to say really great things about a program that we fund was actually, you know, it was a little exciting from a really weird point of view. So when I started my rehab, I was contacted by one of the nurses, and her name is Jacinta. I hope she doesn't mind me mentioning her name. She's no longer with the program, but Jacinta was absolutely fantastic. Having that really good understanding of what might be actually on my mind and what I needed at the get-go, and then melding and moulding the program, the rehab program, to suit my knowledge and understanding and the encouragement levels that I needed, as opposed to what somebody else might have needed. As I referred to earlier about laying on that table and intellectualising what was happening whilst I was on that table, I did actually intellectualise a bit of what was happening with my rehab program as well. And that was a little bit of a challenge. It took a couple of times to actually finally work out what I was doing and actually take it on and reorientate how I was actually interacting with Jacinta, and making use of the rehabilitation activities that she was actually trying to engage me in. And part of that is actually driven around the My Heart, My Life book. So it's not a rehab program that's built out of nothing. It is got some very strong evidence around it, and it actually fitted me really well. You know, some of the things that I was able to do was, you know, really understand why I should stop smoking. And that's one of the big challenges, I think, for people who do smoke is, why do you stop smoking? What is it about heart disease that smoking triggers? So we went through all of that, and she gave me some things to read, and set goals to stop smoking. I wasn't smoking a huge amount, but I had been smoking for a very long time. Any smoking is not good smoking. So that actually gave me some really good information and encouragement to actually stop smoking. Unfortunately, during the time between my first admission and my second admission, I did then have diabetes, type 2 diabetes. So that did complicate things a little bit. And it was then another notch to, okay, how do I manage that along with everything else? But I did get there. I eventually took a decision to actually have stomach surgery and make sure that I could actually manage what was happening to me, because obviously over, you know, the 53 years of my life, 54, 55 years of my life, I've been having some real struggle with that. And some of that may have been as a result of some of the drugs that I was taking, such as the depression medications. So on the whole, I feel that I've actually really gained a huge amount from cardiac rehabilitation. I think the strong take-home points for me are that there is an ability to have it recognised, that a person who is discharged from hospital actually may be in no condition headwise to be able to understand and self-manage their life immediately when they actually really need to do that. That often, you know, for all in good intentions, nurses and cardiologists or medical specialists at the time of discharge and even after it actually are looking very focused at a person. So this is the heart condition. And what's needed is actually some other wraparound warm, fuzzy stuff that actually looks after the mental aspects and the ability to actually get on and self-manage your condition, to be active in what you do and how you live and how you look after yourself health-wise. So for me, those things are very important. They also, I think, help consumers, patients, to actually take charge of what they're doing, and helps them to understand and to be able to ask the right questions of their medical specialists, including their GPs. So being able to have a constructive conversation and go when they see their cardiologist, to actually have confidence in understanding what their cardiologist is saying, but also knowing your part in your care. And that, I think, is a really critical thing, especially in these days where the expectation is that people will actually take more active involvement in their direction. So I think that's about it for me. In that.
Thank you, Ali. That's wonderful. I'd now like to introduce Professor Steve Nicholls, who will talk about secondary prevention evidence and update us on key learnings from the most recent American Heart Association virtual conference that was actually just last weekend. Professor Steve Nicholls is the Director of Monash Heart, Monash Health, Director of Victorian Heart Institute and Professor of Cardiology, Monash University, with a research focus on developing new strategies to reduce the risk of heart disease, spanning preclinical, human and clinical trials. Professor Steve Nicholls is a world-renowned cardiologist, multiple award winner, more than 770 manuscripts, book chapters and conference proceedings, and he's been able to raise more than $100 million for research funding. Thank you.
Thanks, Margaret. Good evening, everybody, and thanks for the invitation. And thank you, Ali, for sharing your experience with us. You know, we always can learn from stories like yours. So thank you for sharing that with us tonight. What I'd like to do over the next 30 minutes is to highlight where we are in terms of the evidence for cardiac rehabilitation. It really sets the scene for the projects that you've already heard about from Matt Worthley. And then what I'd like to do is I'd like to highlight a number of the recent trial results from both the American Heart Association meeting, and if you'll indulge me, a few from the European Society of Cardiology a few months ago, from the perspective of targeting the risk factors that we know are important in driving kind of the risk of heart attack and stroke. This slide summarises my disclosures. So if we start with cardiac rehabilitation, I think we all acknowledge the important benefits of cardiac rehabilitation, but one of the challenges that the field's had is how do we put that all together to show that it ultimately means that a person is less likely to come back to hospital, they're less likely to require another stent, they're less likely to have another heart attack, and they're less likely to die. So what do we know in terms of the evidence? We look back to 2012, we see the results of the RAMET study. This was a pragmatic, randomized controlled trial of cardiac rehabilitation in practice compared to usual care. It was started in 1997. It was powered for a total mortality study, but it was stopped early because recruitment was slow. There was no changes in the secondary endpoints. You can see there was no benefit in mortality, although it was small, and that's kind of where we were. In 2016, you fast forward to a Cochrane systematic review. That has the power of being able to incorporate the results of 63 randomized controlled trials involving more than 14,000 patients and look directly at the question, was there a benefit of exercise-based cardiac rehabilitation versus no exercise controls, allowing for up to 12 months follow-up. In that systematic review, we saw evidence of a reduction in both cardiovascular mortality and hospitalisation. Not necessarily surprising, we did not observe a reduction in total mortality. Interestingly, we did not see a reduction in either myocardial infarction or revascularization. There was some improvement in measures of quality of life, and that at the point in time was considered to be Class 1A evidence establishing the efficacy of exercise-based cardiac rehabilitation for reducing morbidity and mortality, particularly due to cardiovascular causes. However, we know that cardiac rehabilitation comes in all sorts of shapes and sizes, and is not necessarily effective in routine practice due to variable delivery and participation. Here is findings from an UK national audit where they really went around and evaluated all the cardiac rehabilitation programs according to centres. And what they really were able to find that only 30% of sites were considered to be high performers. So yes, we have a referral and a dropout rate that issues that we need to deal with, but we also need to deal with being able to enhance the quality of the cardiac rehabilitation that we provide at each site, both in terms of the quality of the program and the diversity of the options that we give for our patients. If we move forward to 2018 and we look at a systematic review, now you look at 22 randomized controlled trials, nearly 5,000 participants, again looking at exercise-based cardiac rehabilitation versus no exercise control. Again, no benefit in terms of all-cause mortality. Now you see no reduction in cardiovascular mortality. Importantly, you continue to see a reduction in hospitalisation. It's important to note, though, that these systematic reviews are pulling together a vast number of studies which very much differ in terms of their objective, their study design, their quality, and these are a number of issues that need to be taken into how we interpret these findings. And then finally, and this is an important observation led by Carolyn Astley and a number of colleagues, including myself, where we had the opportunity to look at cardiovascular readmission data for patients in South Australia as an audit where we had linked data through SA Health. Importantly, and the sobering effect is only 30% of individuals who are referred are eligible and only 28% attend. So we as clinicians don't refer enough patients, and when patients even are referred, they don't all go. Now, interestingly, looking at real world data from looking at linked data in South Australia, we see that those individuals who do go to cardiac rehabilitation, or at least are referred, have a benefit in terms of less cardiovascular readmission. That may to some degree reflect the type of patient that ultimately goes to cardiac rehabilitation, but it does talk to the potential benefits. So that being said, what are the focuses? And Ali really has outlined a number of them in her own personal experience. And how do I go about trying to reduce cardiovascular risk in the patient with clinically manifest disease? It all starts with lifestyle, diet, exercise, smoking cessation. I think we're now continuing more and more to understand the importance of good sleep health, of mindfulness and well-being. All of these are the cornerstone before we get anywhere near a drug. And then we are going to use pharmacological therapies. We're going to inhibit platelet function, but then we're going to target a number of cardiometabolic risk factors. We're going to target lipids, we're going to target blood sugar, we're going to target blood pressure, and more recently we have some emerging evidence to suggest that anti-inflammatory therapy may be the next frontier for our patients. We know that LDL cholesterol lowering is critically important For a generation, we have performed large clinical outcome trials. They have consistently shown us that lowering LDL cholesterol with statins reduces cardiovascular risk. The degree of benefit is much greater in the patient with established disease, and there is a direct relationship between the degree of LDL cholesterol lowering and the degree of cardiovascular benefit. Our guidelines increasingly emphasise trying to take patients with established disease to lower and lower LDL cholesterol levels, exactly like you saw in Ali's kind of story. But we know, as well as we treat patients with statin therapy, that many clinical events will continue to occur. This slide summarises the major placebo-controlled trials of statin therapy. In every single one of those studies, the statin reduced events, but the greatest relative risk reduction in any of those events was 45%. So it tells us that the majority of clinical events will still occur even when we treat patients well with a statin. This is very important data that was presented at the European Society of Cardiology earlier this year. And while it reflects European data, the sobering reality is that it very much reflects what we see in our own country. And what they presented here is they've looked at patients with established atherosclerotic cardiovascular disease. They've looked at the use of lipid-lowering therapy on the left, and they've looked at the percentage of individuals who attain guideline-mandated target goals for LDL cholesterol on the right, looking at both the 2016 targets that aim to get people to an LDL cholesterol below 1.8 millimoles per litre, and the 2019 goal guidelines, which would actually advocate trying to take people even lower, down to 1.4. Importantly, on the left, more than 85% of patients are treated with at least moderate intensity statin therapy. A number of patients are having combination therapy on top of that with ezetimibe and PCSK9 inhibitor. You see a small number of people who are prescribed either low intensity statin therapy or other lipid lowering therapy, and in some cases no lipid lowering therapy. In general, we're doing pretty well from that perspective. Where we are failing is reaching the targets that we've set for ourselves. Overall, 30% of patients get to the 2016 treatment targets. If you look at in red, in the high intensity statin treatment patients, it's not even 50%. So we need to be much more kind of effective and diligent in the way that we target LDL cholesterol. Now, we know that one of the factors that will influence our ability to do that will be our ability of our patients to tolerate statin therapy. And while we kind of ignored statin intolerance for many years, it is real. And if the patient sits in the room and tells you they cannot tolerate the statin, then you have a challenge in terms of their lipid lowering. There are estimates that up to 1 in 5 patients treated with a statin will have significant muscle symptoms. Now, this is a result of a study that was reported a number of years ago, but it does give an important take-home message. It was a study called GAUS-3. It involved more than 500 patients who all had documented statin intolerance to multiple agents. They were randomized to treatment with atorvastatin or placebo for 10 weeks, and then were re-randomized to the other agent for another 10 weeks. And on this slide, you see what happened to those individuals. We could reproduce the muscle symptoms on the statin alone in only 42% of patients. The rest of the patients either had no symptoms whatsoever, or they only had symptoms on the placebo, or they had symptoms on both the placebo and the statin. And it does talk to the fact that a nocebo effect is certainly something that we do need to consider. It doesn't mean our patients are crazy. It just means that we have to work closely with our patients in terms of trying to get them onto more effective lipid lowering therapy. And at the AHA meeting this year, a very small study, but one of the more relevant clinical questions was asked in a study called SANSON. This was a study of 60 patients at one site in the UK. They all had statin intolerance. Every patient received 12 bottles of drugs, 1 for each month. In 4 of the bottles was a statin, in 4 was placebo, and in 4 actually was nothing. And patients were randomly rearranged in terms of the sequence that they took those bottles. And they were followed over 12 months. And they were asked to use a smartphone application to rate on a monthly basis what their average statin intolerance symptom score was, from 0 at no symptoms to 100 really bad. And on the right, you see the main result of the study. The average intolerance symptom score was 8 in the months when individuals took nothing. It was 15.4 when they took the placebo. It was 16.3 when they took the statin. And that really does reinforce that many patients will actually reproduce the symptoms even if they just take anything. Again, this can be an important tool to help us work with our patients to more effectively get them onto appropriate lipid-lowering therapy. More recently, we've seen new LDL-lowering drugs, the PCSK9 inhibitors. What they do is they essentially increase the expression of the LDL receptor on the liver surface so it can remove more LDL and its cholesterol from the circulation. In the first generation, we saw monoclonal antibodies. These agents lowered LDL cholesterol by up to 60%. We subsequently saw 2 large cardiovascular outcome trials, one in patients with stable atherosclerotic disease, one in patients who'd had acute coronary syndrome within the last year. Both of them showed clinical benefit by adding a PCSK9 inhibitor to a statin. More recently, we've seen the development of RNA inhibitory agents, which reduce the production of PCSK9 in the liver. And here you see early findings from a program of an agent called inclisiran. It inhibits PCSK9 by reducing the synthesis within the liver. You see LDL cholesterol lowering in the order of about 50%. But what's really quite striking about this agent is that after a single injection, if you follow these patients out for 180 days, you still see up to 40% lowering of LDL cholesterol. That is a potential game changer in which additional lipid-lowering therapy may be administered in an injection 2 to 3 times a year. This agent is undergoing further evaluation at this point in time. What about triglycerides? The higher your triglycerides, whether it's a fasting or a non-fasting test, the higher your level of cardiovascular risk. There's been a lot of interest in the use of fish oils. We know that they will lower triglyceride levels. And we have been very excited in recent years to see the results of 2 clinical outcome trials administer sufficiently high enough doses of EPA to reduce cardiovascular events. The first was JELIS, an open label study in Japan, and more recently the REDUCE IT study, which really showed a profound reduction compared to mineral oil. At the AHA, we saw 2 clinical outcome trials that evaluated the effect of a different preparation of fish oil, one that contained both EPA and DHA. In the STRENGTH study, of which I was the global principal investigator, we compared EPA and DHA to a corn oil comparator and saw no benefit whatsoever. In the OMEMI study, European investigators studied about 1,000 older individuals after a myocardial infarction and showed that a slightly lower dose of EPA and DHA similarly had no clinical benefit. So I think certainly EPA may work, but EPA and DHA does not. Another important signal from those studies is that the fish oil treated patients have a higher rate of atrial fibrillation. We see it here in STRENGTH. We saw a borderline statistically significant signal in OMEMI, and in fact in the REDUCE IT trial with pure EPA, we saw exactly the same signal. So we need to explore this further. We understand now the factors that influence triglyceride-rich lipoprotein metabolism. So we can now start to actually target triglycerides in a different way. We know that there are important factors such as apolipoprotein C3 and a family of angiopoietin-like proteins, 3, 4, 5, and 8. The genetics tell us that directly regulates triglyceride levels and cardiovascular risk, suggests that it's causal and suggests that targeting these factors may be of cardiovascular benefit. We now have agents. Here you see the ESC results for antisense therapy against either ApoC3 or angiopoietin-like 3. And you have dose-dependent lowering of triglyceride levels up to 50, 60%. Early studies look encouraging. They will need to move forward into large clinical outcome trials to look at both efficacy and, importantly, safety. Lipoprotein a has emerged as an important risk factor. It plays a causal role, not only in atherosclerotic disease, but importantly also in calcific aortic stenosis. That is supported not only by the population studies, but also by the genetic studies. And the genetic studies would suggest that lowering Lp(a) should lower cardiovascular risk. We now have new agents that specifically lower Lp(a). We already had antisense therapy you see Lp(a) lowering up to 80%, and that agent has already entered a large cardiovascular outcome trial that we are running. And at the AHA, we saw very similar findings from an RNA interference approach. So it's a very exciting time where we will definitively be able to ask the question, not only is Lp(a) bad, but by lowering it, will we do good for our patients? If we move to diabetes, we've seen a large number of cardiovascular outcome trials. We've seen the benefits of the SGLT2 inhibitors. Some of that may relate to heart failure outcomes, and we've seen new studies, specifically in the heart failure setting, where we have seen that benefit. Now we've seen the emergence of the SGLT1 inhibitors. And at the AHA, we saw two results. One conducted in patients with diabetes and chronic kidney disease, where we saw improvement in cardiovascular events. And the second on the right was conducted in patients with a history of heart failure, whether that was with reduced or preserved ejection fraction. And again, we saw clinical benefit. So we are going to continue to see work in this space as these agents move forward. In parallel, we've also seen a number of studies show that injections of GLP-1 receptor agonists have cardiovascular benefit. And most recently, we've seen the development of oral agents that act in a similar way. Not only will that be of potential benefit for patients with diabetes, but may actually also be of benefit in the setting of overweight or obesity. We are currently conducting a study called SELECT. SELECT is a study of more than 17,000 individuals over the age of 45 with established cardiovascular disease who have a body mass index of at least 27. Importantly, they do not have diabetes. And they are being treated with either semaglutide by subcutaneous injection administered once weekly or placebo. And we think it's the first legitimate shot in the overweight obesity clinical trial setting to see a clinical benefit. Again, we wait the results of those studies. I wanted to finish just with a few final points. Firstly, the benefit of colchicine. We'd already heard reports in early studies suggesting that this anti-inflammatory could be repurposed from gout and pericarditis to actually atherosclerotic disease. And at the European Society of Cardiology, we saw the results of the LODOCO-2 trial, a study conducted in Australia and the Netherlands, a highly statistically significant reduction in cardiovascular events. And importantly, in a smaller study of patients treated immediately after myocardial infarction, a very strong trend, albeit just missing statistical significance, of starting colchicine early. They are continuing to follow the patients in that study, and my understanding is that over time we will continue to see potentially greater benefit there. Now, I wanted to finish with what I think is a really important observation, which wasn't a clinical trial at AHA. And it was a study called HARP-MINOCA. And it took women who presented with a myocardial infarction who did not have any evidence of obstructive coronary disease on angiography. These women underwent 3-vessel OCT imaging within their coronaries that really enabled for us to look at the artery wall, and then subsequently underwent cardiac magnetic resonance imaging of their heart. Here you see the findings of the OCT imaging. Of the 145 women who underwent OCT imaging, we were able to observe a culprit lesion in nearly 50%, the majority of which was atherosclerotic. There was a little bit of spasm, there was a little bit of dissection, but the reality is that if you look hard enough, you will find atherosclerotic disease. And it really tells us that we should continue to treat these patients aggressively. Now, what did we find if we looked at the CMR? The CMR, we found evidence of infarction in 33%, regional injury in 21%. And we only found that 26% of these women essentially had a normal heart on MRI imaging. You see a number of other causes that can be found: myocarditis, Takatsubos, other cardiomyopathies. It really tells us the importance that we should investigate these patients, that the identification of an angiogram that looks okay is not the end of the deal. And as my co-moderator at the AHA, Roxana Moran, so eloquently said in a way that I couldn't in the public domain, this is an important observation because it really shows that in the women who are presenting with troponin rises, and non-obstructive disease, they're not crazy. We find causes in overwhelming majority of them. To summarize, if we integrate OCT and CMR together, the OCT culprit leading to CMR evidence of infarction or regional ischemic injury in 69% of these women. The ischemic CMR findings leading to 44% of patients with no OCT culprit, you should continue to suspect spasm, thromboembolism. But if you combine OCT and CMR imaging, the investigators were able to identify a cause in more than 84% of the women in this study. This is a very important observation that I think helps us in a group of patients where we don't investigate them well enough, we don't treat them well enough. The evidence is really there that we should do that. And finally, I wanted to leave you where I think we're going to put this all together moving forward. We're going to take patients with atherosclerotic disease, we're going to treat their LDL appropriately with a statin, and then we're going to have to work out what else may be driving their risk. And you see a whole host of factors here on this slide. We need to see if we can identify appropriate biomarkers that can triage the right patient to the right drug, because we cannot give every patient every drug. They won't take it. It's too expensive. You'll ultimately have patients taking drugs that will cause side effects and not benefit them. Let's target the right patient to the right drug to lower their risk. And the clinical trials have and are in the process of identifying the pathway forward for that. On that note, I'll thank you for your attention.
Thanks, Steve, for a fantastic in-depth talk. What we're going to do now is have a panel discussion, and it's going to involve our guest speakers, Ali and Steve, along with Vanessa Poulsen, who's a Senior Heart Health Coordinator for the Heart Foundation, and Carolyn Astley, who's the Vice President of the Australian Cardiovascular and Rehabilitation Association, ACRA. So if you have any questions, if you could just go to the participants button and you bring up the participants, and at the bottom right-hand corner, you can see that you can raise your hand, and then we can unmute you and you can ask your question. Maybe while we're letting people work out how to do that. Steve, what do we need from a health system perspective to adequately resource and support cardiac rehab services to deliver evidence-based programs?
Well, I think first of all, I think we need to be able to provide a range of options for patients. And I think we've learned that a lot. I think that if you think about what the major challenges are, doctors don't refer because they don't think it's going to work. So we need to make sure that we've got the evidence that already exists, and we need to work out where the gaps are to provide more evidence that it will work. The second thing is patients don't go because it's at an inconvenient time where we could have delivered in other sorts of ways. And I think that the idea of being able to have a raft of measures, to use the politicians' terms, is really important. Let's tailor the right patient to the right cardiac rehabilitation program that will help them. It doesn't need to be one size fits all. And then I think we need to embed these things as quality standards within our cardiology units. We should hold ourselves accountable that patients should not go home without antiplatelet therapy, lipid lowering therapy, advice on lifestyle, smoking cessation, all of these things. Everybody should have their HbA1c checked, for example, but everybody should have been offered cardiac rehabilitation. And I think that we need to hold units and accountable to that. And as we moved into a value-based healthcare system moving forward, these are the types of things I think that health services will be kind of monitoring. You're on mute.
Do others have questions?
Oh, sorry, was that me?
Yeah.
Stephen, I was actually really thrilled to hear you talking about the whole statins issue, because as a person with arthritis, the statins, I've had a big struggle with that over the years, is actually which one, how much, because often it feels like it's exacerbating my arthritis. So, and it was through some discussions with my cardiologist that actually we got to one that's kind of bearable, but trying to find something that is probably better would be fantastic. And I think it's a very important thing.
Look, I think, Ali, statin intolerance is hard, and you know, it's an issue by itself. And as you said, you know, we're dealing with a lot of patients who may have arthritis or a range of other chronic pain kind of syndromes, and so we need to realise that we're not just managing an issue in isolation. And so, you know, by the time patients come to see me for this, their GP and potentially other treating doctors have pulled their hair out in addition to the patient. And so whatever solution is there is going to be a long haul. But, you know, we can get many patients, not everybody, onto some form of effective lipid lowering regimen. It may not be as ideal as we'd like, as those European kind of slides would like. But I say to my patients, look, if I can get your LDL cholesterol 15 or 20% lower than it is today, then I've lowered your risk. But it does take a lot of work, and new agents will help.
Well, while we're waiting for other people to think, Ali, while you're there, what did you think of the cardiac rehab program that you participated in? What did you like, and what do you think things could change or improve the program that you participated in?
There was a couple of things. Well, there's a whole range of things actually that that I liked about my rehab program. Firstly, that I could actually access it when it suited me, and living in the country, it's not easy to get access to the program. You know, there are only limited number of face-to-face sessions. The kinds of information and support that were offered was actually really important, because it could be tailored to my knowledge, and be supported when, so Jacinda was really fantastic at actually reading my tone of voice. You know, I know that they're using VC now as well, so that's actually an added benefit. So, you know, when I was feeling a bit distressed about something or not understanding or frustrated, she actually responded to that. And so that was actually a real key thing. But it was that in those, particularly in those early weeks, actually really getting to grips and understanding what was happening to me, and, you know, why I was, you know, being impacted. You know, one of the things out of my surgery, having stents, it actually, I all of a sudden had a huge amount of energy, which I didn't have before. So, you know, it was really, really noticeable that what happened with the stents. But then, you know, making sure that, you know, I was resting properly but taking my drugs properly and exercising properly, and just knowing that I could actually ring somebody as well if something was going a little pear-shaped, but I didn't actually think it was really GP worthy or cardiologist worthy. It might have just been something happening with my head that I wasn't quite gelling, or a piece I might have been wanting to confirm something. So all of those things were, you know, really quite important to me. And actually, you know, I guess the other thing is actually being valued as a person, and a whole person. So, you know, Jacinta really understood or got to grips with actually all my little issues and foibles and and other things that actually made me a person and how I actually might react and be active in my self-management, which, you know, was really, really important to me.
Hello, everyone. Can you hear me? It's Professor Robin Clark from Flinders University here. My question is to Steve, and actually to all of the panel. Steve, I've been sitting in conferences for a very long time looking at this amazing data of fantastic therapies, but a lot of the therapies measure prescribing rates. What concerns us, you know, cardiac nurses at the coalface, is adherence rates. How many of those tablets are actually swallowed is one of the most important aspects of cardiac rehab, I think. And Ali, I really want you to come in on this anytime, is that negotiation that, you know, Jacinta convincing you that taking all these tablets are going to be a good thing. They're going to be good for you. Like it's a contract. You go, okay, I can see the benefit. And you talked about finding energy, and you talked about feeling so much better once you've got your medication sorted. So maybe Steve, start with the issues of adherence versus prescribing, and then maybe Ali, some practical hints for our audience on improving adherence.
So look, I think adherence is a kind of underrated kind of point here. And there's actually nice data from the UK that actually integrates both the intensity of treatment and adherence, and actually shows, surprise, surprise, that if you're given less intensive therapy but you actually take it, then you're going to probably get as much benefit as being prescribed more intensive therapy and not taking it. Back in 2013, the Americans updated their guidelines, and what they kind of adopted at that point was what they called a fire and forget kind of strategy, in that you really only had to measure the cholesterol once. You could write a script and then you didn't really have to follow patients up. Don't worry about checking their lipids again, all this kind of stuff. Well, that's fine if everybody takes the medications. And it's not actually going to be fine, because not everybody's actually going to get the same degree of lipid lowering and get to the goals you want them to be on. And some people, like with blood pressure, will need combination therapy. But you then lose the opportunity to check adherence and all of these types of things. So it's really critical.
What I'd say also, or add to that, is that people change over time. So, you know, it might be that they put more weight on, or they might take weight off, or they might be eating better food. You know, one of the things that I do these days is to eat oats for breakfast. I have oats every morning for breakfast. It might be bircher muesli, or it might be cooked porridge, but I have oats for breakfast. And so, you know, people do change. So that fire and forget is really, that's not valuing patients at all, and their conditions. As far as adherence goes, I'm probably not a really good example there, because I've been taking drugs for a really long time. In my 30s, I started with my psoriatic arthritis. So I have over time actually had lots of drugs off and on. There's always the thing about getting off the drugs, because it doesn't feel natural. But also, you know, coming out of hospital with a bag full of drugs and going, I've got to actually take this one this many times a day, I've got to take that one that many times a day, and trying to sort that out is actually a bit of a challenge. But, you know, one of the things that I found was I actually could negotiate with my cardiologist, and she would give me a clear view of, okay, you take this lot here, this is going to be for this long. And if all goes well with this checkup, then, you know, we might be able to drop this one off, or we'll drop those 3 off. So that was actually something to look forward to. I'm currently doing some negotiation with her on dropping my my blood pressure medication, because my blood pressure is so well controlled now that sometimes I just go, why am I still on this? You know, it's always around the 100/80 something or rather. So it's really well controlled. I do understand that the statin or the cholesterol lowering drug is probably going to be a life thing, because I do have non-dissolving stents. So that is going to have to be an important thing for me. So it's actually understanding some of that stuff that's really important as well.
Thank you. We've got a question from Aileen. She would like to ask a question, and then Imelda. So Aileen first. Thank you.
Okay, thank you. Thank you, Ali, for sharing your journey with us. I found it very interesting. And my question is about the change that you mentioned just before. So how do you think the cardiac rehab program prepared you for this change over time, especially in regards to motivation? So this is my first question. And the second question, I would like also Vanessa from Heart Foundation to contribute. It's what Heart Foundation have as resources to provide this motivation to patients after these 2 or 3 months of cardiac rehab.
So the cardiac rehab program really actually starts you on the road to changing habits. And so, you know, it was the key thing around stopping smoking. It was the key thing around changing diet. I'd already been doing exercise and had a personal trainer working with her twice a week. I am a bit inhibited by arthritis at times, so it kind of goes up and down. But it is that habit changing. I think that is one of the really important things that that the cardiac rehab does, particularly the longer term. I mean, it was really, you've got that underlying support for, you know, regularly for quite a period of time, and it's actually focused on you. So some of the face-to-face stuff is group work with a bit of one-on-one, but the CATCH program is this real focus on you as what your needs are to recover. And I found that, you know, that was actually really great. You know, most of our sessions were reasonably long. Some of them were a little bit shorter. But, you know, whatever I needed at the time is actually what was provided. I hope that answered everything you asked.
Vanessa, you were asked about Heart Foundation resources.
Absolutely. Thanks, Marg. So I guess Alini's question was sort of post-cardiac rehabilitation. I'd probably just start with the reference to the Mahatma Life book that Ali did refer to as being her Bible or her guide that she would have received in hospital and then utilised through the CATCH program. So that certainly is a stalwart of the Heart Foundation, and we're really fortunate that the SA Health has been funding that for all of our ACS patients across the state for quite a number of years now. So, you know, we're really confident that our South Australian cohort of patients are leaving hospital with a, you know, a fantastic evidence-based resource to set them on their recovery journey. So that's sort of one component of what we offer. It's not just a book. I guess the thing that we do layer over that is that people like myself go into hospitals and health services and do provide supportive training around what to say with that book. So I'm really interested, Ali, by your experiences of how much you retained in hospital. That's always a really interesting thing for me to consider when I'm asking staff, you know, to sort of follow our 6 steps to cardiac recovery and really plant those seeds of information, you know, for that longer term follow up with cardiac rehabilitation, cardiologists and general practice and practice nurses. There's sort of our window is getting smaller and smaller with our really quick turnaround and discharge times in hospitals these days. So we do put a lot of emphasis on that part of the patient journey. I guess the next step we look at is really all of the other information the Heart Foundation does provide the community. So we are seen as a credible source of information for people out in the general public. Certainly we have Heart Foundation walking groups which operate across the country and are a great way for the community to get involved and get active, and for people who live alone, who aren't confident to walk on their own, it's a really great opportunity. It's also got really good social and emotional aspects as well. So that's sort of one formal program we offer. Beyond that, we do have our Heart Foundation helpline. So that's our free call 13 11 12, or indeed email us for questions, and we have staff that are available for, as you said, Ali, some of those questions that may not be worthy of a trip to the GP or knocking on the cardiologist's door, but something that you're still sort of needing clarification for. We have a team that can certainly are there and available and have a lot of time to support the community. We've got really great videos on our website and our YouTube channel. So our 6 steps to cardiac recovery, I mentioned, we do have a video component of that for consumers as well. That certainly can sort of help display the information in a different format. And I'd probably just say one of the most popular things we find of information for the general public is our recipes. So it's actually, translating all of this information that you've been given about these new medications and this new diet, and then, well, how do I do that in my day-to-day life? So some of our heart healthy recipes are probably our most popular clicked on item on our website, and we certainly know that that's something that really does help people to really then manage their life long term. Okay, I've had all the information, but let's put it into practice and live in a different way that's healthier for our hearts. Yeah, so hopefully that's sort of a bit of an overview for you, Eleni, of what the Heart Foundation offers.
Yes, terrific. Thank you very much, you both.
Imelda, you had a question.
Yeah, thanks, Margaret. I've got a couple of questions if I can. The first one is to Ali. I actually worry a lot about people like you, Ali, who were in hospital for a very short period of time and then sent out into the wilderness. At what point post-discharge do you think you would have preferred a phone call from someone to say, hey, how are you getting on?
Oh, within 24 hours.
Yeah, okay.
Particularly as I live alone, it is kind of really, you feel very disjointed and don't know what you should be doing, where you should be doing it, how active you should be from the get-go. So there's a lot of things, and it is just that, are you okay?
Yeah.
Yeah, question.
I think there's a lot for all of the agencies involved in this work to sort of get together and think about how we might be able to offer some support, earlier support than what we currently do in that. And Margaret, if I can ask a second question, from the health professionals online, what strategy do you think we should use to gain buy-in from the health professionals to say that cardiac rehab is so important and get your referrals happening?
I can probably answer to that, certainly from the Northern Health Network, where Ali came through. The buy-in is actually is that we have a whole health team, and the big buy-in is actually been from our nursing staff. So with electronic medical records and electronic ordering, it is very automatic now that any patient who comes in with acute coronary syndrome, when I do a ward round the next day, they're already referred to cardiac rehab program. And so that happens. We have, again, Heart Foundation assistance there, these little tick box reminders, the checkbox that nursing staff use, both at admission and discharge, to make sure that everything's done and education is done. They have them My Heart, My Life book, they are referred to cardiac rehab. So it's actually automatic. So in general, it sort of happens sort of under the radar, even from a cardiologist, the patient is referred. It's interesting to hear about how that phone call 24 hours after discharge may be important. That's not just with acute coronary syndrome, but almost anyone who's discharged from hospital.
Yep.
And there are quite a few strategies that hospitals are taking on now, that one of the senior nurses on the ward will ring people the day after they've gone home, just to make sure they're safe, and that if they have any questions, and to sort of just assist them to say, how are you? Which is, the are you okay question is just so important. And that's recognised, I think, for heart disease, but also for most other patients who've had the fun to be admitted to hospital. Matt wants to answer, and he'll speak to Carlin's experience.
Yeah, look, I agree with all of that, and maybe it's really sort of weaving it in from a cardiology perspective, weaving it in at the earliest possible point. We have incredibly hardworking and dedicated registrars that move through the process that have quite a structured 3-year program. There's a number of things they need to do and a workbook that they need to tick off. I'd be very surprised if any of our trainees are at all educated that rehab is a bad thing. I'm sure they all believe that rehab is a good thing, but it's done by other people somewhere else. And so, the opportunity of weaving it into their education program, as part of their workbook, or moving with half a dozen people through the rehab journey, will give them first-hand experience and just open their eyes. So, things like this may be of benefit.
And even if it's done a little earlier, I've had a few of our medical students, and I've encouraged them to attend cardiac rehab sessions, and it's always been very positive and quite eye-opening for them. I think it's hopefully formative experience.
Margaret, we're designing a heart hospital at the moment, which is kind of an interesting project, and within that hospital is actually a cardiac rehab gym. And that always just delighted me from the start, because everywhere I've always worked, the cardiac rehab, if it's on site, is in a building out of sight, out of mind, usually way beyond the car park and everything else.
Might be shed.
Yeah. And so there's a couple of advantages to doing this. And now I realise that that's an opportunity I get that not everybody gets to do. But by putting it in the building, we are saying, look, prevention and rehab is actually just as important as stents and operations. We will get the chance to be able to provide a rehab service in the building for people who choose that that's the program that they want to come back to. But it does give us an opportunity to patients who may be a little uncertain during that hospitalisation, we could actually show them, say, actually, you know what, we're going to take you downstairs and show you what it looks like. But also it enables for us to integrate the cardiac rehab experience into the process of our junior medical staff, our nursing staff, frankly, our senior medical staff, to all actually, and it helps, it's all about demystifying it. It's about providing the evidence, actually being very clear about what the evidence is, but it's also about demystifying what rehab is and what it isn't.
Thank you, Steve. And thank you, panel members. Are there any other questions from everyone here at the webinar? If not, I might hand over to Carolyn, who's going to do a wrap-up of our session this evening. Thank you, Carolyn.
Sorry about that delay, everyone. I just want to formally invite everyone who's been on the call this afternoon, on the webinar this afternoon, to join us in making our video wall. Matt touched on this at the beginning of the session, and we think that this will be a great promotional tool in both online and social media, and also through our presentations. So you saw an example of what needs to be done. Because you participated in this webinar, tomorrow you'll be sent a link from the Frankie Films production group, who are going to make the video wall for us. They'll invite you to book a time over the next couple of weeks. And once you've confirmed your time, you'll receive a Zoom link and an example of what you need to say. And then you just need to spare 15 minutes of your time and have a laptop, a phone or a tablet device and go online and make a little face-to-camera video like Matt and John Beltrami did for us. And we've got 2 weeks to do that. So I'd love you to be able to promote this whole idea to your registrars and anyone who was unable to come on the webinar tonight. That would be absolutely wonderful. We've got an aim of trying to get 100 people on the video wall, and we've got a whole lot of consumers lined up as well. So we really need to spread the word and encourage people to participate. And just to wind up, I'd just like to say some thank yous. Special thank you goes to Matt and Ali and Steve to present to us today. Ali, you were absolutely amazing. Your story was just fantastic, and it was so inspiring to see how you've worked so hard to reduce your risk factors and create a better life for yourself. Steve and Matt, thank you so much for supporting us, and a special thank you to Margaret. So you did such a wonderful job straight after your clinic this afternoon, chairing and bringing us all together. Just a thank you to Matt Lachenal. He's been the behind the scenes AV manager. It's not easy doing all this sort of thing on Zoom. And none of this would have been able to happen if we didn't have Novartis supporting us. We thank Novartis so much for your support and acknowledge your work that you do in improving lives for patients with cardiovascular disease. So thank you everyone for joining us. Have a wonderful rest of the evening, and we'll hope to see you soon, and please participate in our video wall. Thank you.
So thank you everyone. I realise there's a few people who missed out on questions, but hopefully it has been a good evening for you all, and we look forward to participating on the video wall. Good night.